Good evening. My name is Beth Smith, and I am a doctoral student at Liberty University in the Department of Counselor Education and Family Studies. This evening I will be presenting the cognitive processing therapy known as CPT. Your word is a lamp to my feet and a light to my path. Just as we allow the Lord to lead us as a lamp through our life, we as counselors are that lamplight for our clients in guiding them on paths to recovery. CPT is a specific type of cognitive behavioral therapy that helps patients learn how to modify and challenge unhelpful beliefs related to the trauma. This evening's agenda is the cognitive theory and overview, central constructs, cognitive processing therapy, what causes dysfunction in the theory's view, nature of therapy, role of assessment, role of the client and the counselor, goals of therapy, a case example, critique of CPT, and key resources. The cognitive theory, an overview. The cognitive theory was mostly developed in the early 1960s, where it became popular and it shifted away from our traditional behavior-focused approaches in mental health. This new research prompted that pathway by empirical approaches for exploring cognitive processes such as learning and retention. This was developed by Dr. Aaron Beck, who was the foundational theory of cognitive therapy, and while he tested assumptions of Freud's psychoanalysis with clinical depression, he also found data from discourse with patients and descriptions of their dreams suggested that their depression was associated with deep-rooted beliefs regarding failure and defeat. So these beliefs cause patients to automatically make negative assumptions, and it didn't bring out those positive assumptions that we see in current CPT practices. So importantly, Beck realized that beliefs could be identified and captured, which means captured and directly examining the patient's automatic responses and tracing them back to their source. So we really work through the trauma, where we're not focused so much where we were in the early phases where we're obviously focused on dreams and the subconscious. Now we're looking at how do we walk clients through that trauma and how do we help them therefore process. So essential elements. So fundamentally based on the individual's perceptions, and that's key when we're talking about cognitive processing therapy. Individual perceptions, because every client, every individual is different and their views are different and their experiences are different. So rather than focusing on the event itself. So we have to look at how do they perceive that experience and their recovery. It's time limited. There's not, this does not go on for years. This is average of about 12 sessions. So it's changes in eccentric disruptive thinking which contribute to cognitive changes that are beneficial for treatment. So we're trying to change those cognitive functions and how do we then perceive our trauma and how do we perceive our present self. So based on patients' thoughts and behaviors and determined by the perceptions of behavior on the patient. So we're looking at the patients, we're looking through their lens, through their view, and then how do we help them on that path. Principles and goals of cognitive therapy. Collaboration is key, and we're talking collaboration from practitioners to counselors all the way down to our clients. And I don't say all the way down, I just mean we have to have that team approach. So the counselor is part of that client's social setting. So our viewpoints matter, our actions matter, and how we connect with our clients, because we don't want to connect with them and cause our clients negative and erode those positive beliefs and therefore bring out those negative beliefs. We have to check ourselves before we work with our patients. So when working with a client, a counselor must utilize a collaborative approach because it's a team approach, it's a community approach, enabling the client to solve problems together and have that key discussion, those key discussions that will lead to that active recovery and treatment. So we work together to transform the counseling to address the issues related to the detachment or to the disorder or to the disordered thinking, to reinforce the idea that what are our clients' fundamental weaknesses, and then how do we therefore tackle them and turn them into a positive recovery and positive thinking. We also want to talk about the credibility. So due to changing or unreasonable distorted views, it is a main goal of cognitive therapy that the therapist needs to demonstrate their credibility in those counseling sessions. They have to be reliable. They have to have the accurate perspective. They have to really listen to their client and perceive what they're seeing and what they're feeling in relation to the event, not just the event itself, but in relation to the event. So we have to establish that credibility. The therapist should not act as that argumentative piece. We want to be the ones to really establish our credibility and opening up those lines of communication to allow our clients to talk freely, to talk about those perceptions and those feelings and those emotions tied to those event or events. So we are responsible for examining the altering and irrational or distorted nature of their beliefs and encourage them to examine their own thoughts. Which is why when I say we walk through the process with them, we have to have them walk through those events and process those feelings that they felt and those feelings they currently feel to find that true path to recovery. With the client taking the lead, and we want to be the facilitator in this. We don't want to be the one driving. We want to be the facilitator and allow those thoughts, those emotions, those feelings, and those unhealthy thoughts to drive so that we can change the way that they view. We can change the way they're thinking and bring out those positive reinforcement pieces. So we don't want to contradict, we also don't want to suggest evidence. And when we're talking about that, we don't want to suggest things or come off abrasively that we might contradict the client's negative beliefs. And in some ways, we might reinforce those negative beliefs. So we really have to rely less on more authoritative or assertive form of credibility. Cognitive processing theory, an overview. So this is a particular type of cognitive therapy. It has been shown to be effective when treating post-traumatic stress disorder in victims of abuse, violence, natural disasters, or any other traumatic experience. And currently is widely used with military veterans and current military service personnel. It's a short program that typically, like I said before, comprises of about 12 sessions. So the therapist can support the patient who has experienced major trauma in assessing thoughts that have been developed from the experience. So we're looking at what thoughts and feelings have manifested due to those traumatic experiences, especially when we're talking about maladaptive behaviors and self-blaming, depression, which have been obviously heightened because of the post-traumatic stress disorder, in conditions like especially anxiety and depression, which we see it's a high prevalence in our servicemen and women. So the person suffering gets an opportunity to question these concepts. They embrace the alternative perspective of how do we look at this. And some other forms of CBT. CPT necessitates at-home work. There's a lot of narrative writing. There's a lot of coursework that patients really have to do when they do come to their sessions. It's really going to help them unpack that trauma and, more importantly, unpack those feelings and self-perceptions that they see of themselves. And how can we change those? How can we give them a more positive outlook on their life and themselves, even with that trauma? Because as we know, the trauma is there, but how do we find those pathways around the trauma to help our clients heal? History of CPT. So, well, the initial emphasis of CPT was actually related to victims of sexual assault. Sexual assault. Recent methods and programs effectively applied the therapy to a variety of other traumatic events. So they noticed that, especially in, like I said before, service members, they noticed that it didn't always clearly relate to rape or a sexual assault. There are so many other traumatic events that trigger PTSD and trigger these negative thoughts and these maladaptive behaviors to counteract those feelings and perceptions. So the first manual was published in 1993, which was related to PTSD. The first study actually included 35 participants in a treatment group, where 9 clients in an individual treatment group. So The next group did include women who had experienced interpersonal violence in adulthood and childhood and their index trauma to begin treatment. So most importantly, the Department of Veteran Affairs did receive a grant to conduct a study on CPT with its veterans. And these veterans range from males, mostly from Vietnam War era. It has been used widely on other service members from different um, wartime eras. But given that most of them have received treatment for years, they all had a history of substance abuse. So subsequently, due to their PTSD, the lack of understanding, the lack of compassion, and just an overall lack of care um, led to prolonged PTSD, which was obviously was related to prolonged substance abuse, which was prolonged health issues, which we see a high prevalence of in service members from that wartime era. So we said, like I said, 12 sessions among 40% of those veterans who had immediate impact in the field. And those are those veterans that had the frontline combat. Not all of them had that, a lot of, especially if they were reinforcement soldiers. So we're talking about the impact in the field. And this was especially prevalent in our medical soldiers who saw gross trauma and were severely affected and suffered deeply with PTSD and coexisting disorders. So it also noted that there were more commonalities and differences among trauma survivors, and that veterans' interperceptions of their trauma were very similar to those of the interpersonal violence victims in earlier studies. So we're talking about those early studies when they focused it more on the rape and sexual assault victims. And they saw that there was way to work this in and to work with veterans who were experiencing PTSD. So central constructs. Most adults with diagnosis of PTSD can benefit from CPT, and even mature adolescents may additionally benefit from this type of treatment because their executive functioning, they can actually work through that trauma, they can unpack it, where younger adolescents, and it really depends on what your maturity range is. It's really individual, case by case, especially when we're talking about our adolescent population. Can they handle walking back through that trauma and come out with positive coping mechanisms, and being careful not to re-trigger and add to that PTSD? Since CPT strives to transform patients, some medical professionals and researchers believe that it may be particularly useful with individuals who anticipate to encounter more trauma, and this is extremely prevalent with our military population. They might have gone on one deployment, or they were at a training exercise when something traumatic happened, because it does happen quite frequently. That does not mean that that service member is not going to ensue more trauma throughout their training or their mission essential duties. So what we do notice, though, is if we do intervene and give them the therapy they need when they do experience those prolonged traumas in the future, we see less of the effects of PTSD and the manifestation that comes with PTSD, such as substance abuse and coexisting disorders, physical ailments. So it's extremely beneficial to get that treatment to be able to handle those concurrent traumatic events that they might encounter. So the sessions, like we said, were 12 weekly sessions, approximately 60 to 90 minutes. And it's somewhat depending on the specific needs of the client. And that's something that we really have to consider is, does the client need 12 sessions? Does this client, most likely they will, but do they need that 60? Do they need that 90? Maybe they need more time. It really depends on the client's ability to handle that trauma, to work through that PTSD. So initial sessions generally concentrate on obviously we know the psychoeducation piece. How do we inform our clients? How do we give them the education, the knowledge on what they will gain from treatment, what the long-term, short-term goals are? And then through those following sessions, the therapist will work to collectively to recognize and investigate how trauma may have influenced the patient's thoughts and beliefs. And this is especially true for those who suffer from other coexisting ailments, physical, mental, and how that PTSD or those traumatic events severely affected their everyday functioning. So is it normal to experience discomfort during CPT? Absolutely. Nobody wants to walk back through that traumatic event, and it can be extremely painful, which is why pre-treatment screening is vital to ensuring that that client and that therapist are both ready to walk back through that path. So, causes of dysfunction. So we're talking about the dysfunction in cognitive processing therapy, which can arise from several factors. So we're talking about our patient-related factors. We have therapist-related factors and therapy-related factors. So some of the patient-related factors are severe to complex trauma. Patients with multiple, they may have multiple traumatic events that they have either encountered, and it might not just be related to, especially if we're talking about veterans, it might not be related to their service. It could be something that happened in their childhood, in their adulthood outside the service. And all those things combined are part of their history, are part of their manifestation. We really have to look at those complex traumas. And then how do we go forward in walking through and treating them and changing that mindset? Co-occurring mental health issues. As we know, when we have severe depression, anxiety, PTSD, especially when we throw the substance abuse piece in there, it can interfere with that process because now we're dealing with a multifaceted issues, and we really have to make sure the client is ready. Even with those co-occurring mental health disorders or issues, we have to make sure we're encompassing them all and understanding where our patient is at. Lack of motivation or engagement. Um, Most patients are going to come to you because they're ready. They're ready. They're ready to work through the process. They're ready to heal. They're ready to find that recovery. But sometimes that initial push to start working through can cause a client to shut down. They can lose the motivation. They can disengage as a way of protecting themselves. So we have to make sure the patient is fully committed to the therapy process, and so we don't hinder a future session or the original outcome. So therapist-related factors. Obviously, us as counselors, um, we have to make sure that we're ready. Just as much as we want to make sure our client is screened and ready to go, we also have to make sure that we are ready to work through this. And one thing that I do know that I've read about, that I've researched and experienced is especially inadequate training, especially working with special populations such as our veterans. If we're not able to understand the background, if we're not able to understand the culture, then it's going to be very hard for us to engage with our client, to really make that client therapist connection, that professional connection, to dig deep into that trauma. When a client feels insecure or they don't feel they're being heard or misunderstood, that can hinder our progress and delay the therapy, and sometimes even end that therapy in the middle of the process. So therapist burnout, high levels of stress, burnout. If we are not taking care of ourselves, if we are not actually realizing where we are before we start the process, and that comes with every single session, every single interaction we have, then we can also hinder the process. So therapy-related factors, rigid application of techniques, not adapting to the therapy, not adapting to our client, our surroundings, their feelings, their emotions, their present state. Inappropriate timing, starting CPT too soon after a traumatic event. Maybe a soldier has just come home from a deployment or a very traumatic experience, and we jump too soon, assuming that our client is ready. Maybe they don't even know. Maybe the client doesn't even know that they're not ready, and they haven't even gotten through that crisis period, and it can be extremely counterproductive and hinder the process. Addressing these factors involves ensuring proper training for our therapists. We have to foster that therapeutic environment and really work together in how do we tailor this therapy to either this group, because even though we have individuals on our group, we can all find commonalities together. And what are the specific needs of each patient? Even in a group, we still want to know what are the specific needs. One might need more than the other through certain aspects and steps in our counseling process. So next we're going to talk about the nature of therapy. So we know that CPT can be delivered both individually and in structured group sessions. So we can do either, and it's really yet again going to boil down to what do our individual clients need? Can they function well in a group? Or have they suffered so greatly and have other coexisting issues or insecurities that are not going to allow them to function in that group? And they might need to do individual CPT. Regardless of modality, patients have out-of-session practice assignments. So like I said before, they're going to have those pieces they're going to have to work through, and that's really that individual time to create that narrative, to write down that trauma in whatever capacity that patient has. We're not going to ask them to write an absolutely 100% detailed time, date description. We just want to get the feelings, the thoughts, the emotions, and that perception, that lens that we're going to look through to see how our clients view their trauma that they have been through. And more emphasis placed on the cognitive techniques. So treatment begins with obviously the psychoeducation piece, the thoughts and emotions. They become more aware of the relationship between their thoughts, emotions, and that event, and they begin to identify, and that be maintaining the PTSD symptoms. So how can we then therefore change that mindset? Impact statements are extremely crucial. This gives details about current understanding of why traumatic events occur and the impact it had on the beliefs about themselves and others in the world. Unfortunately, when a traumatic event happens, we're not always thinking about those beliefs. We're thinking about the event, the raw, the down and dirty, the emotions that that individual might have felt in that moment, but we're not asking them those hours, minutes, days, months, years later, what was their beliefs of themselves, others in the world, because it changes their viewpoint on other people. It changes their viewpoint on the world, especially if others didn't come to their rescue or didn't realize or recognize that trauma. And that is extremely true. And through research and patient encounters of veterans is that they were not those that were there to protect them, just surround them, were not there in that time of need. And so that breaks that trust and it changes their entire worldview. So the patient begins a formal processing of trauma. The patient writes a detailed account of the worst traumatic experience, or that maybe it was just that one traumatic experience. And that is going to carry them through until that next session. And then we break that pattern of avoiding thoughts and feelings associated with that trauma. So we try to break that pattern of negative thoughts. So then we come to where the patient has developed skills to identify and address unhelpful thinking. And we're talking about those negative thoughts, those negative self-perceptions in relation to that trauma. So we really want the patient to develop that ability to use the adaptive strategies that we teach them outside of treatment to improve the overall functioning and quality of their life. Role of assessment in the CPT process. So, as I've stated a couple times, we do start with that psychoeducational piece. Patients undergo instruction about PTSD, thinking, and emotions. Automatic thoughts. Patients acknowledge unhelpful inherent thoughts connected with their signs and symptoms. And this can be very individualized even in a group setting. The impact statement. Some patients never either have the ability at that time to really sit down and talk about and write down that and how that traumatic experience and how it shaped their beliefs about themselves and others and people, how it shaped those moments and that period after, and where that traumatic experience led them. Traumatic processing. So patients compose an extensive description of the greatest distressing event, and a key point in this is the patient is going to disclose and compose that description in the way that they remember, or the way that those thoughts and feelings drove them to remember. But what this does help do is break that downward spiral of evasion, of those erosive thoughts that have taken that client down, and really having them look at the trauma, look at everything, kind of like a still picture, and how we can change those thoughts, work around it, knowing that it's there, but knowing that we can get past it. Cognitive technique. Therapists use Socratic inquiry to modify maladaptive patterns of thinking. Patients continue to assess and adapt their beliefs about traumatic events, which strengthens their general well-being and quality of life. Role of the client and counselor. Client and counselor both in CPT, they have individual roles and group roles, and they play significant parts of encouraging recovery and rehabilitation. So a counselor, as we all know, foundation of counseling is we listen and we instruct and we facilitate. So the counselor is attentive to the client's experience, feelings, emotions associated with the trauma. They supply psychoeducation and PTSD and CPT. We direct and we facilitate. We are not controlling the group. We are the ones that are facilitating our clients to work through this process, adhere to the practices, and then promote discussion, present those Socratic questions, and assist clients in working through challenging intrusive thoughts and views. We self-empower. We educate our clients to cope. We model problem solving, model how we manage, how we distress management techniques and procedures. And we monitor, of course, our clients' progress. And that could be done through, our assessments after, the times that we do talk to the clients individually. And that could be something that we do on the side. But mostly we're going to monitor that group feedback and what are we getting out of the group? How is the group moving forward in this process together to enhance the therapeutic results for the group and for all the individuals participating? So for a client, we're empowering our clients to communicate those concerns. We want them to freely discuss those traumatic encounters. And as the sessions move forward, clients do become more open and more honest about those traumatic encounters because they are also in groups, especially when we're talking about our veterans. We're in groups of people who experienced some of the same situations, events, although they're all different because everybody processes them differently. But those emotions and those raw thoughts, we can really connect together. And that's why that group is so essential to healing together because they have commonalities. They encourage and they fully engage. Develop and execute. So that this comes down to we develop those new thoughts and we execute that new way of thinking. The empathy techniques for coping in opposition to negative thoughts. We have to help our clients to be able to combat those negative thoughts, to replace them with those positive coping skills. Engagement and self-reflection. So it's the client's role. They need to stay engaged. They need to stay on top of any assignments that are given. And this is going to help them with that self-reflection to really expose their traumatic event and expose that occurrence and really help them reflect and move forward and work through it. Commitment. The client's pledge to attending those sessions, completing the required work, and engaging fully in a therapeutic process. Goals of CPT. Cognitive processing therapy assists clients in understanding and adjusting their abnormal thoughts and emotions after a traumatic event, thus decreasing the severity of PTSD symptoms. So two of the main goals obviously are decreasing PTSD signs and symptoms and also getting unstuck. We talk about unstuck when it comes to CPT, and this educates clients to critically examine and assess their beliefs which motivate their emotions. So when we have those negative self-talks, when we have those distorted thinking and view of ourselves, that's going to motivate our emotions and drive our behaviors. So we want to offer tools to help them dissolve stressful patterns and move forward with their recovery. CPT provides a safe environment for trauma processing, aids in identification of disordered thinking, and teaches individuals coping strategies to improve their functioning in varied areas of life. Case study, the veteran. So I'm going to talk to you about Kelly. She's a 24-year-old single white female who presented with treatment for approximately 6 months after a traumatic event. And her traumatic event was associated with military sexual trauma. And this occurred during her military service in Afghanistan. Kelly reached the rank of Sergeant First Class while on active duty in the Army. So background. So we know that Kelly is the second of 3 children in her family. She does have 2 parents. But unfortunately, before the divorce, she characterized that her father was an alcoholic. So she lived with an alcoholic father who was rarely there, was employed, but rarely there. She claimed that her father was emotionally detached from the family, especially right after the divorce. So she really didn't have that father figure in her life, or that proactive father figure. She had a close relationship with her mother and her brother and sister. She denied having any significant mental or physical problems related to those adverse experiences. However, she stated two significant traumatic events did happen. One of those was her best friend did commit suicide, and she felt extremely guilty afterwards due to the fact that she didn't stop it. Kelly also experienced the loss of her brother due to a scuba diving accident when he was 18, and no treatment was given. She did not go through therapy. She did not talk about it. Nevertheless, she acknowledged to using alcohol and drugs to kind of combat the depressive feelings, the PTSD potentially of those events. So during Kelly's service, the traumatic event that brought her into treatment was that Kelly was in an operational exercise. This was a night exercise. She was assigned as a primary driver to a truck with another older, established or seasoned soldier um, for this exercise, and this was prior to a deployment. But during the operation, it was dark out. The male soldier and her were in the cab, and during a brief halt during this exercise, the male soldier grabbed her hand and placed it in his pelvic region. He then proceeded to undo his pants and place her hand on his genitals. He asked if she liked it, and due to her fear of retaliation or fear of this is an older soldier, I am a new soldier, I am younger, I don't have a say in this because if I do, I can make things worse for me, because that unfortunately was the culture. Shortly after the radio broke silence, they were instructed to move forward, and when she did this, she did pull her hand away. And when this happened, the soldier got angry, slapped her across the face, and told her that next time she was to move only when he said so because he was the NCO, and to her to remember that. An NCO is a non-commissioned officer, and he was a higher ranking officer. So therefore she knew that she was then in a place where she didn't have a decision to make. She had to follow orders because of fear of that retaliation or that reprisal that might come on to her. And she knew that the attacks would potentially continue if she did speak up and say anything to anybody. So Kelly lived with the traumatic event for many years before reaching out to a women's veterans organization for help through the CalVet network in California. Kelly developed a severe eating disorder, she was hospitalized 4 times during her late 20s. And this resulted in some long-term health effects, unfortunately, that had prolonged psychological distress that added to that PTSD and those coexisting disorders. Kelly did redeploy 4 months after she came home from her first deployment. So after that initial deployment where the traumatic event happened, she was then thrown back into the mix and encountered months of sexual harassment and reprisal for her noncompliance by her supervisors. So she again was thrown back into an environment. The traumatic event was different, but it compounded upon the initial traumatic event that she experienced. At the age of 35, after she had her first child, she had retired from the military, and she was admitted to the hospital for treatment by her medical doctor, and therefore started, which is where the CPT treatment started for her. So she went through technically there's 3 phases. So she went through the psychoeducation piece that we've talked about earlier. Then she went through the traumatic processing, involves client writing down. That's where the coursework or the homework piece comes in, where they're having to write down that traumatic event, write that impact statement, and then the counselor uses methods of interviewing to guide those suffering with PTSD and exploring how they think about the trauma. And she could help pinpoint the damages that were done that were especially through the self-blame through this trauma. And then phase 3 is modified views and thoughts about traumatic situations. And this is where we talk about walking back through that traumatic experience and changing the way that we think, taking away that self-blame, taking away those negative thoughts and those self-perceptions to help create a more positive construct. Because like I said, working around that barrier because that traumatic event is there, but how can we then move Kelly forward and process it to a place where she is functional and she has the ability to move on and accept that it happened, but accept that recovery is possible. Critiques of the cognitive processing therapy. So efficacy in real world environments. Some clinicians are suspicious that CPT's beneficial outcomes in research environments are applicable to real world clinical practices. Individuality. There are concerns regarding CPT that can be tailored to an individual client's requirements and circumstances. The danger of aggravating symptoms. And that is something that you hear a lot about CPT is can you counterintuitively put a client into CPT, have them walk through experience that they might not be ready to process. Yes, we do have the pre-screening and the pre-therapy to make sure that we are ready for the process, but there is that danger of aggravating symptoms that could unfortunately cause more distress or prolonged mental health issues if we are not actively monitoring our patients and understanding what the process, having our patients really understand that psychoeducational piece. Multiple medical conditions, especially when it comes to either health conditions or coexisting mental disorders like such as anxiety or depressive disorders. If we're not addressing them, if we're not bringing light to them through that process, and we don't approach it correctly, we can unfortunately, and some people do say we can impede the process and cause more harm. Developmental and childhood trauma. So our adverse childhood experiences are ACEs. Some professionals dispute whether CPT proves successful for clients. I do think for adults, it is beneficial because we're unable to unpack that trauma. We can actually view that trauma, walk back through it. Obviously, like I said before early in the presentation, when it comes to adolescence, we want to make sure we're doing this with our mature older because they are able to hopefully handle and process it. But for our children, obviously CPT would not be something we want to use because we don't know if that would essentially work in really having them understand those adverse experiences. Mortality harm, the implementation of CPT with moral injury is controversial. And cultural diversity, offering CPT to historically diverse populations increases concerns. The stabilization process. So we really want to make sure, like with all therapy, that we are being culturally sensitive and culturally diverse and understanding cultures and how cultures view mental health, how cultures view therapy processes. Once we understand that about our clients, we will hopefully not fall into those pitfalls of being culturally insensitive and not being equitable in our treatment practices. So keep in mind that every person's experiences with CPT can vary, and it is essential to consider our client's particular requirements and circumstances during therapy. And here are the references used for this presentation. Thank you so much.